My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation educational series webinar. This evening, we're going to talk beyond plaque and nodules, understanding IL-17 biology across disease states. Our moderator this evening is Dr. Leon Kursik, who's the president of the International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai in New York, adjunct clinical professor of dermatology at the Indiana University School of Medicine in Indianapolis, and medical director of physician skincare, derm research, and skin sciences. Our presenter this evening is Dr. Naeem Issa, who is dermatologist and drug discovery researcher, assistant professor of dermatology at the University of Miami School of Medicine and George Washington University School of Medicine and Health Sciences in Vienna, Virginia. We'd like to thank our supporter, UCB, for making this educational event possible. Before we begin, if you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select the phone call in the audio pane and the information will be displayed. If you're having technical issues, please submit your questions using the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be sent to you 1 to 2 days later. We'd greatly appreciate it if you could fill it in and send it back to us. And within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. Again, please submit your questions using the question chat pane on the right-hand side of your screen. And if time permitting, we will direct those to our faculty. So without further ado, I will pass the floor virtually to Dr. Kursik.
Thank you, Roxanne, and good evening, everyone. Welcome to another International Dermatology Education Foundation's educational series. Tonight is a very special night because we don't have one of those what I call the unlabeled programs. This is gonna be a not necessarily unlabeled. There is no label here. We're gonna discuss IL-17 itself, and we're gonna discuss IL-17 across the different disease states. But before we do that, I'd like to tell you a little bit about International Dermatology Education Foundation. We are a nonprofit organization with a principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. And since the pandemic, we're continuing our mission, not only in US, but in North America, in Canada, in South America, in Europe, as well as in Southeast Asia, as you can see from many different programs that we have executed in the past. So tonight, as I mentioned, we have a very special program, and you can also follow us on at Instagram, Facebook, as well as LinkedIn. But also the easiest way will be to go to idefeducationalseries.com, not only to register there, but also to see our upcoming educational events. Now, back to tonight. So we're gonna discuss IL-17, and you know, we have a bunch of biologics now. We're lucky in psoriasis, especially, we have more than 13 biologics, and they are either TNF-alpha inhibitor, IL-17 inhibitors, or IL-23 inhibitors. And we use those drugs left and right. Really, we know we feel very comfortable, their efficacy and safety. But you know, how about in other disease states and overall IL-17 itself? How does it function? What does it do? And especially now that we have a IL-17, not only an A blocker, but an F blocker. As you know, IL-17, it's a spectrum of between A all the way to F. So with that in mind, I'd like to invite one of the best and I would say young dermatologists who are rising up there. Dr. Naeem is a good friend of mine, and he practices in Virginia, as well as he's an assistant professor of dermatology at University of Miami, as well as at George Washington School of Medicine. And before I pass the baton to Naeem, I'd like also to thank our supporter UCB, which with their grant made this program possible tonight. So I thank you so much. Naeem, please take it from here.
Thank you, Dr. Kursik, and good evening, everybody. It's such a pleasure to be here and to do another of these webinars with you. So as I get the slides ready here, and we can go ahead and rock and roll with some IL-17. Let's see.
You know, while you were getting that ready, I do want to mention that unlike other programs, you can ask anything and you want. We don't have to be unlabeled. Please feel free on the chat line, on the Q&A, feel free to ask anything, of course, relevant to IL-17, but there is no, since we are not on an unlabeled program, you can ask anything you want as long as Dr. Issa knows the answer.
Wonderful, yes, and this is truly a rare, experience for us to be able to do something like this through a venue like this. So please take advantage of that. So without further ado, this is the first time we will be, presenting this sort of, and would like to introduce to you the segment on the role of interleukin-17. So as aptly called in health and disease, sounds like a marriage, but we have the dual role of IL-17. Where we will look at its protective immunity function as well as its pro-inflammatory and pathogenic function. So let's look at the yin and the yang. All right, so disclaimers here is that this presentation is intended only for healthcare professionals and that the images shown here we have the rights from third-party copyrights that are in place to show these images. So tonight's objectives will be to explore the roles of the IL-17 family of cytokines, the role for protecting the immune system, as well as the pro-inflammatory and pathologic functions across the disease states that we know and love, including psoriasis, psoriatic arthritis, as well as hidradenitis suppurativa. So the goal for tonight is for you to have a holistic understanding of what IL-17 and its isoforms are doing and how to look at the disease states through the lens of IL-17. And so with that, let us go ahead and introduce the landscape of the IL-17 family of cytokines. So as a broad overview, as we know, IL-17 cytokines are important for triggering beneficial responses, right? Just like anything with homeostasis, if you have a dysregulation of these cytokines, that can contribute to systemic inflammatory diseases. And in those states, inhibition of IL-17 in different capacities can help in these specific diseases and then restore that homeostasis, leading to a healthier state. So on the left side of the screen here, you can see the contributions of IL-17 cytokines toward good health. This includes protection from infectious diseases, such as bacteria and fungal elements. We can have maintenance of the microbiota on the skin as well as in the gut, leading to microbiome homeostasis. In addition, IL-17 in its own right is able to modulate metabolic function, and hence it can help regulate sugar, it can help regulate adiposity, visceral fat, so on and so forth. And a particular interest to me, by the way, is this final piece where IL-17 can contribute to wound healing. And at Miami, by the way, so we have one of the best wound centers in the country, and so we all have to spend some time dealing with chronic wounds. And it is very interesting to see the interplay of IL-17 in the role of chronic wounds, specifically, venous stasis ulcers, and how IL-17 can actually come into play with the metabolic function and how that leads to, the dysmetabolism, leading to further wound healing problems and so on and so forth. So it's just a fascinating interplay, for me at least. And then leading to the right side, you can have the contribution of IL-17 to different diseases. In their own right, IL-17 family of cytokines can lead to neurodegeneration, and we're talking about Alzheimer's disease, frontotemporal dementias, Parkinsonism, Huntington's, so on and so forth. There's something there with neuroinflammation, to be exact, with IL-17 cytokines as well as the receptors and their different isoforms can be leading to disruptions of the blood-brain barrier as well as different neuronal circuitry functions and so on. Again, very fascinating in its own right. Then we have the classic chronic inflammatory autoimmune states. This is where you have your plaque psoriasis, psoriatic arthritis, hidradenitis, things you already know and love. And then lastly, also fascinating, is tumorigenesis. What's IL-17 got to do with it, right? Tumors, malignancies, liquid malignancies, hematologic malignancies, as well as solid tumors such as pancreatic cancers, breast cancers, and so on. IL-17 actually has quite an interesting role, and briefly, without getting too much into it, is that IL-17 actually is a double-edged sword for some of these tumors. So in some cases, IL-17 can actually promote metastasis, such as in breast and gastric adenocarcinoma, esophageal squamous cell carcinoma, and then it can also be protective, on the other hand, for chronic lymphocytic leukemia in some cases. It can be protective in pancreatic and so on and so forth. So depending on the tumor, there's different roles for the same IL-17 cytokines. And we're really trying to get a handle on what all that means and what that may entail for patients who are undergoing psoriasis treatments while having active malignancies. All right, so a lot of fascinating things for the IL-17 class. So as we get into the biology here a little bit, there are 6 known members of the IL-17 family class of cytokines. They go from A to F, IL-17A, B, C, D, E, and F, but then they have this unknown one, which is aptly named unknown, and that can also signal in its own right. So, but they all share an amino acid sequence, right? So that's why they're all in the same family. But very importantly to note is how they may pair up with each other or across each other. So either through homodimerism or heterodimerism, because that can lead to different signaling cascades. Most importantly here to learn is that IL-17A and 17F, as shown on the left side of the screen, they share a particular subunit together. And because of that, not only can those A and F pair with themselves, giving homodimers, but that shared sequence can allow for heterodimerization. All right, so that's pretty unique amongst this class. Whereas the other members of the class can only homodimerize, and hence that's why you see those color coordination there. Then with these different pairings, I should say, they go on to signal through the appropriate IL-17 receptor, right? So key concept number 1 here is that you have the pairings of the cytokines, right? That's level 1 understanding. Then level 2 understanding is going to be, what is the setup of the receptor? All right, and this is very important because the receptor is not just one subunit, it's actually 2 different subunits. On the left side of the screen here, you can see that the IL-17 receptor, in this case, which allows signaling of A and F, is comprised of the following 2 subunits. Number 1 is IL-17 receptor alpha, right? That's one subunit. Then you have IL-17 receptor C subunit. So the alpha and the C subunit heterodimerize together to make that receptor to allow for the signaling of those 3 pairings of 17A with A, 17F with F, and 17A with F, right? Then it gets more complex. There is beyond that one type of heterodimer receptor. And you can see the rest of it here starts to become dizzying. If you look at IL-17B, that homodimer will signal through IL-17 receptor with 2 very different receptor subunits. You have a quote-unquote unknown subunit that's still not yet fully named and characterized. We still have a lot to learn from that structural biology. And also you have the second subunit being IL-17 receptor beta. What is the importance of that? We're still studying it, still figuring that out. Look at IL-17C. Here, the receptor subunit is comprised of the already known IL-17 receptor alpha, but then it pairs with IL-17 receptor epsilon or E. Completely different structure than what you see on the left side of the screen, right? And then you can see so on and so forth, right? So I don't need to necessarily read you all of them, but the whole point is that you have a large permutation of different subunits of the receptor because it heterodimerizes, and hence that will allow for different combinations of the different IL-17 family cytokines to pair up and signal differently through these different receptor subunits. And the subunits here are found on different cell types, such as your T helper 17 cells. They can be found on different immune cells like macrophages. They can also be found on keratinocytes. They're found pretty much everywhere and anywhere, right? And we'll get into that in a little bit. So key concept without necessarily making you cellular biologists here, right? 6 cytokines, 17A through F, right? Homodimerizations, heterodimerizations, and you have different subunits of the receptor that can mix and match and cause different permutations of signaling. And hence, it is very, very diverse. And that's why one pathway is not sufficient for us to just look at when we look at inflammatory disease states for this reason. All right, so now that we know that underpinning biology, right, let's find out what cytokines are secreted by what cells, right? So IL-17A and F was what we first saw, and the first homodimers and heterodimers. Here you can see that they are released by a number of different immune cells. The classic cell that is releasing these cytokines include the T helper 17 type cells, but then these are the adaptive cells, right? You have your innate cells and you have your adaptive immunity, right? So your adaptive immunity leads to T helper 17, and the Th17 leads to the cytokine production, right? Then you also have the innate arm, which includes the gamma delta T cells. You have your innate lymphoid cells, natural killer cells, natural killer type T cells, which is a different. NKT is different than just NK cells, right? You got to dig back to some immunology there. You also have neutrophils, and this is fascinating, mast cells. I wonder if anyone in the audience actually knew that mast cells can express IL-17 cytokine and actually cause them to be released. And I'll give you a little fun fact. You know, in not shown on this slide is that you also have eosinophils, and there is some evidence that for hidradenitis, when you look at the tunnels deep down, that there are eosinophils that are actually producing IL-17. So the more we know. Now, what's shown a little bit differently here on the left side of the screen, while we know the receptor has both A and C, what we didn't show in the last slide because there wasn't enough room was that you can also have IL-17 receptor C homodimerized with another C subunit to allow for signaling, right? So these pairings of the cytokines A and F can signal through two different types of receptors setup, and that's very critical to think of when you think about patients that are responding or not responding to different medications. Moving on, let us look at IL-17B as boy. So IL-17B is produced by a whole different set of cells, right? Here is more in the central nervous system. You have your neuronal cells. You have like your microglia, you have your Schwann cells, so on and so forth. So these ones are truly just secreting IL-17B. But outside the nervous system, you also have your chondrocytes, right? So these are found in your cartilage, in your bones. And you also have various epithelial cells. Epithelial cells found in the mucosa, epithelial cells that are found on the skin, those found in the GI tract, so on and so forth. So IL-17B looks very varied, if you will, based on the different originating cell types here. So it's almost like a renaissance cytokine. Moving on to IL-17C. This one it's a little bit busy, but C is mostly a keratinocyte-driven cytokine. Right, so keratinocytes, which can be found on the skin itself, but also you can find keratinocytes on mucosa as well, vermilion mucosa, as well as the tongue, GI, and then that interface between the GI tract and the different openings like the anus as well as the mouth. What happens with these epithelial cells, right? And you also have the GI and respiratory tracts, which have their own epithelial cells, and they can secrete IL-17C. But so all of these epithelial cells are responsive to IL-17A. Right, so IL-17A binds the epithelial cells to allow for secretion of IL-17C. But then you have your innate immunity through interleukin-1 beta and TNF alpha. And these two innate cytokines will signal through toll-like receptors on these epithelial cells to also produce IL-17C. I hope you're starting to see a theme here that IL-17 production for the different isoforms even can come from multiple sources. Right? I like to call this all roads, many roads leading to Rome, right? Because nature is smart. It likes to think of different pathways in case something goes wrong. It likes to have a contingency path in order to get to the same destination. And that's why we have adaptive and innate immunity, and IL-17 is a convergence between the two. And that is important evolutionarily as different organisms and humans have come to the fore. Then last but not least, we have IL-17E here, right? And IL-17E is also a little bit of a renaissance because it's released by all sorts of cells, including dendritic cells, which are your antigen-presenting cells, your macrophages, which could be part of your innate immunity as well as their adaptive immunity, T cells, neutrophils, you got mast cells, Panus cells in the GI tract, mucosal epithelial cells. It's everywhere. So IL-17E is also important for homeostasis. And then a little bit backwards, you're going from E to D. D is found, toward the colonic epithelial cells, and as you can imagine, could be important for mucosal immunity. All right. So again, this has been a very bio-heavy kind of discussion. Hopefully, you're still with me, right, as we're going to get into more clinical relevance for you. So here we have that IL-17 family of cytokines has diverse beneficial functions. All right. Let's look at those beneficial functions. So number one, so 17A and 17F, we have a good infectious agent protection. So on the skin and oral mucosa, it's fighting fungus. We know that, such as Candida. IL-17A in of itself promotes wound healing, actually. So that's interesting. With wounds, by the way, you want to have an acute wound regeneration phase, reparative phase, where it's supposed to be acutely inflammatory. That is really important because what happens when you have IL-17A, you're actually recruiting some macrophages, and then you have these pro-inflammatory macrophages for the first 2 to 3 days of the wound healing process that then become more of an adaptive and regulatory immunity. So you go from an M1 type of pro-inflammatory macrophage due to IL-17A that shifts to a type 2 M2 macrophage that allows for healing. So something to keep in mind as well. IL-17A also modulates metabolic function of adipocytes to regulate body temperature, right? So that's your metabolic function and visceral fat. IL-17C and D can contribute to an antimicrobial response that is necessary and sufficient to maintain homeostatic balance of the gut, right? So again, gut microbiome and homeostasis. And then 17E, right? But not so much talked about. We're learning more, and I hope you look forward to our future future writings and articles about what the E is doing, is helping regulating inflammatory responses in certain pulmonary infections, as well as parasites. All right, so some more biology, all right, but bear with me, this is a little bit of a reiteration. We have a beneficial effects, right, of IL-17 cytokines, right? They signal through different subunits of the receptors, right? Key concept. You have two major types of immune arms. You have your adaptive immunity, that's your Th17 and type 1 lymphocytes, right? Your T cells there that lead to the production of Th17s, right? Especially A and F. And then you have your innate arm, the more emergent, that has urgency kind of inflammatory arm, and these include your innate lymphocytes, gamma delta T cells, natural killer cells, neutrophils, mast cells, you name it. Again, many roads leading to Rome. You have all the 17A and F and the other 17s being produced, and that causes the recruitment of more immune cells such as neutrophils. So you have neutrophil chemotaxis, you have macrophages being recruited, and you have epithelial cells getting turned on and starting to either cause more barrier disruption or thickening, as well as having those epithelial cells act as pro-inflammatory cells in their own right. All right. These things can be protective at first, but then if you don't have the proper seesaw or balance by the regulatory agents as shown on the right side of the screen here, and by regulatory agents, I mean like regulatory T cells. These are the firemen that are coming in and they're just like taming it down with a little bit of water there, right? And you have that, remember that M2 macrophage we talked about in the wound healing, that's important. Th2 cells, also very important, right? This is the other part, this is the opposite side of the Th1. Th2, yes, we think about eczema, but Th2 here is actually balancing out Th1, and sometimes you can lean in a little too much into the Th2, and that's why we have a paradoxical reaction, and we start to see more eczema in our psoriasis patients, and some of that overlap. And lastly, we have like your innate-like cells, we have like ILC type 2 and so on, and you can see the cytokines that they produce. So there's a yin and the yang, and if you start to lose the yin and the yang, you start to get pathology, and then you have pro-inflammation, and then the whole thing goes into disarray, and it goes haywire, right? So then it's just a roller coaster that's going out of control, and we have to then start to tame it down. Okay, now we go into the actual pathogenic inflammation. And this is going to be a real key concept. So this is a pearl I want you to take home tonight if you start to forget everything else I talked about, right? So what happens is that we have adaptive and innate immunity, all right? Again, key concept I've been repeating all evening, all right? When you have at the beginning of the inflammatory cascade, you have antigen-presenting cells, myeloid cells, dendritic cells. These cells are the cornerstones of the pro-inflammatory whirlwind, right? These cells, they can recognize antigens, from your keratinocytes, lupus antigen, so on and so forth, right? They take pieces of bacteria, pieces of peptides floating around, you name it. They present it to other parts of the immune system. They turn on other lymphocytes and innate cells and what have you. So here you have the dichotomy, the split. Your APCs can utilize IL-23, as shown in the top part of the screen here, to lead to an adaptive immune response. That's your Th1 and your Th17 cells, right? That's your classic psoriasis cascade that we already know about from like years ago, from like a decade ago. So through IL-23, all right, we call this the IL-23 dependent pathway, all right? IL-23 dependent pathway, you're getting activation of the adaptive arm through Th17, and then you have further production of your IL-17 cytokines, A and F, right? Then on the bottom part of the screen, this is where you have your innate arm of the immune system that is IL-23 independent, right? We now have two arms, IL-23 dependent pathway that goes through adaptive immunity, and then you have innate immunity, which is the bottom part there, that is IL-23 independent, right? So you do not necessarily need IL-23 in order to get to IL-17. Critical concept, please take that home in your memory banks tonight, because this understanding is a milestone for our cutaneous inflammatory disease states. We did not know this for such a long time, but now we do. Right, so many roads lead to Rome. With that being the case, all right, what are some pathologic outcomes that we get when IL-17 signaling is in disarray? So number one, we have plaque psoriasis, as we already understand, but we also have systemic scleroderma, which is something being looked at right now, as well as multiple sclerosis, right, a neurodegenerative disease. We also have psoriatic arthritis and rheumatoid arthritis. We have ankylosing spondylitis, which you probably have heard of by now, classic hidradenitis suppurativa, and we can find disarray in different levels from the skin into the tunnels as well. And then we have inflammatory bowel disease as well as colorectal cancer. And if you recall at the very first slide from tonight, when it comes to tumorigenesis, here is a call out to specifically colorectal cancer, where IL-17 in the milieu of the cancer actually leads to poor survival and increased metastasis. Other diseases where we have aberrant IL-17 signaling include potentially autism spectrum disorder, Parkinsonism, atherosclerosis. So if you actually take the plaques of atherosclerotic patients looking into their coronaries, when you scoop them out, actually you find what are called foam cells from the macrophages, and you can see that they are actually IL-17 positive. In addition, you have systemic lupus erythematosus, right, SLE. Classically, we think that there's a TYK2 element to SLE, so this is very fascinating to see IL-17 involved. Ischemic stroke and vascular remodeling, as well as the nerves and microglia. Sepsis is another case. Influenza virus associated inflammation, as well as stromal keratitis of the eye, as well as parasitic infections. So essentially, what we're trying to show is that IL-17 signaling is so conserved as a central hub of inflammation that so many different disease states, depending on the compartment of the tissue and where in the body that this disarray is happening, same cytokines, same receptors, different disease outcomes. All right, so let's look into plaque psoriasis. So what is some of the evidence here? Some take-home points. When one does gene expression analysis on healthy skin, non-lesional skin, and lesional skin, all right? And what is lesional skin? It's the actual plaques. When you look at non-lesional psoriasis, you have a patient with psoriasis, but their skin looks normal, but they're a diseased patient. And then you have healthy patients who are demographically matched, but they don't have the actual disease, no psoriasis, so their skin should be healthy when everything else is matched. Here, looking specifically at the IL-17A and IL-17F cytokines, looking at their gene expression, you see that the lesional psoriasis has an increased expression of IL-17A compared to non-lesional psoriasis patients. So there's an increase, almost like a dose-dependent increase on lesional skin versus non-lesional skin. And you can see for IL-17F, there's a much greater increase between the non-lesional psoriatic skin versus actual lesional psoriasis skin. And what we really do find is that IL-17F has at least 30-fold greater increase of expression compared to IL-17A in lesional skin. So we have gene expression there. In addition to IL-17A and F, we have IL-17C. And if you recall, C, if you make it look like a K, will stand for keratinocyte, because you have your epithelial cells, your keratinocytes are the ones mostly producing IL-17C. And similar story here is that IL-17C gene expression is greater in lesional psoriasis compared to non-lesional skin. But in addition, so sometimes, by the way, you can have an increased expression of the cytokines, but it can mean diddly squat, because if you don't have the actual receptor to integrate the signal, you can have all the cytokine in the world if it's not binding to the receptor to give you a signal. Here, we actually have proof that even the receptor to the IL-17C cytokine, which is made up of IL-17 receptor epsilon, there's an increased expression in those psoriatic lesional skin. So here we are showing that IL-17C is greatly expressed or more expressed in lesional skin, as well as its receptors to be able to receive that signaling. So we have enhanced signaling. And as an interesting call out, look at the right side of the screen there. Look at how much expression of IL-23 receptor. Yes, there is some, and that's important because IL-23 can, go and signal through the keratinocytes and of themselves, as well as other immune cells, right, to cause more IL-17C production, as well as other IL-17 isoforms. But the fact that it's not so greatly expressed leads me to believe, all right, as a scientist, and by the way, my background is I have a PhD in cancer biology, so I think science all the time. It's like I like to nerd out. One of my hypotheses is that IL-23 receptor is critical, of course, but it is not mutually exclusive or sufficient to just operate by itself in order to cause further disease propagation. These results tell me that there is another circuitry that is independent, as we saw with the adaptive and versus innate arm. Here we have more evidence that there's that independent IL-17 circuitry that can propagate itself without the need for 23. Right? Then furthermore, this is pretty fascinating. Does disease severity, this is now different than lesional versus non-lesional skin. This is looking at disease severity. The question here was that, do we find more IL-17 cytokine in the serum, in the blood, to correlate with disease severity as defined by the PASI score? On the left side, you can see that with increased PASI, increased disease severity, we see a direct correlation with IL-17A expression. So more IL-17A in the serum, right? There's a great correlation with the disease severity of psoriasis. But what about IL-17F? Here, there may be a slight association, but not as strong as 17A. What could be the implications of that? But we'll keep that on hold. But so there's a slight correlation there. And remember, this is different than just saying that there's more in lesional skin versus non. Is there a true, vector association of a correlation with disease severity by PASI, and whether or not that's the right thing to measure or not for this, it's a whole different story. But disease severity along with 17A and 17F. But there seems to be a pattern. Okay, enough of the psoriasis here, all right? And then reiterating that there's the two pathways leading to Rome, adaptive and innate. One is IL-23 dependent, one is IL-23 independent. But here you have that feedback loop, all right? When you have your IL-17A and F, but also, by the way, you have production of TNF. So let's not forget about TNF. TNF is always in the background lurking, right? It gets a little bit jealous that we forgot to talk about it after all these years. So TNF is lurking in the background. You have IL-17A and F doing their thing, and they're all feeding to skin inflammation, your keratinocytes, as well as fibroblasts, and you name it. The epithelial cells, particularly keratinocytes, talk back. Keratinocytes are pro-inflammatory. Don't forget, keratinocytes are pro-inflammatory, not just barrier and thickening and scale, okay? Being pro-inflammatory, your keratinocytes are secreting IL-17C, which leads back to the adaptive arm of the immune system to make more Th17 to release more IL-17. And then the circuit propagates by itself. And then on the bottom side, the bottom part of the screen, you see that keratinocytes also produce IL-36. A new warrior has come to the battle arena. IL-36 is a part of the innate system that could lead to neutrophil chemotaxis. That's why we can see more of the pustular psoriasis, or you can see the pustules of Kogoge that you see in the stratum corneum when you do a biopsy, and the neutrophilic abscesses and so on and so forth. And so that IL-36 goes back to the innate cells. It can cause neutrophils to come forth. Your innate lymphocytes then also produce more IL-17A and F, more TNF, more inflammation of the skin, so on and so forth, right? So I hope you see that everything, plays in this circus, if you will, right? And that you have different circuitry for propagation of inflammation, right? Then here is another pearl, all right? So if you're getting sleepy on me, don't fall asleep just yet. I want you to take this one home to the bank, all right? Memory T cells, right? Tissue resident memory T cells. What the heck is that? All right, for those of you in the audience who have never heard of memory T cells, what we believe with memory T cells is that this is the reason why the disease gets propagated over time. You think that the skin is clear, right? But if you got memory T cells, the disease comes right back, right? And furthermore, this is the theory as to why you have Kebnerization, all right? For those of you who have not heard of the Kebner phenomenon, it's like you say, let's say you have a psoriasis patient, right? But their skin is clear, they go, they trip, you know, and then they cut their arm on a tree branch or something, then voila, they got a psoriasis plaque there, or in the line of that scratch. Oh, for example, I had a really interesting case where of a patient that did electrolysis actually on her abdomen, and because of the electrolysis, actually saw Kebner phenomenon. I'm hoping to publish this case. So very fascinating, and we believe it's because of the memory T cells, right? So interestingly enough, 5% of the tissue-resident memory T cells in psoriatic skin, right, can express IL-17A and F in those skin cells, right? And we believe that even though it's just 5% of the memory T cells that are there, 5% is sufficient enough to cause a wave of cytokine production, right? It's like the little engine that could, right? So these tiny little memory T cells, right, that the small amount of them that are able to produce IL-17A and F, that could be contributing to disease survival and the perpetuation, right? So, but what on earth happens to them if you were to treat psoriasis with dual blockade of 17A and 17F, all right? Let me repeat that. The question here is that with dual blockade, all right, of 17A and F simultaneously, does anything happen to the memory T cell? Because that could lead to the potential thought of this, you know, in my mind, maybe disease modification, maybe disease remittance, right? Just a hypothesis. So this is what's something called a violin plot, all right? And with a violin plot, you're looking at gene expression sets that is characteristic of memory T cells. All you need to know, you don't need to be a bioinformatician here. All you need to know is that somebody smart designed a set of genes that was to say this X set of genes equals resident memory T cells, right? And when we see these genes, right, we can see that they're just how much of that is going to be in that skin population. So on the left side here, you can see healthy skin. That's the baseline amount of memory T cells. There's such a small amount there. That's a human variation. It just is, right? Then looking at non-lesional psoriasis skin, you can see the violin plot starts to get stretched. So you start to see more above that red line that there's a greater gene set score, meaning greater presence of memory T cells. Then in dead center, you see psoriasis plaques baseline. Whoa, big mama, right? We got a lot of memory T cells there. That gene set score is way above everything else there, right? So we know that they're present. Then this is where you take back to your memory banks. After dual blockade of IL-17A and F cytokine, 2 months in, you start to see a re-regulation back toward non-lesional or even healthy skin, right? That violin plot starts to thin out and move back down toward that red. So you can see that the median is moving back closer to that baseline red line. And then over time, it's hard to see on the screen here, but you can see that from that box and whisker plot, that median goes even further down back toward non-lesional or toward baseline, non-lesional or healthy skin by week 28, right? So the summary of this slide, right, and for what it's worth, right, whatever hypothesis you want to generate from this is that dual blockade of plaque psoriasis, right, when you're looking at the expression of memory T cells in the psoriatic skin, it starts to reduce back toward non-lesional or healthy skin. Could that have an implication when you stop the medication, right? Could you potentially have remittive effect? Who knows? That's a whole discussion that is worth having in its own right, wherever that you stand, around that aisle, okay? But something provocative, something for us to talk about as potential new milestones in this inflammatory disease space. Okay, we're getting there, right? I promise, just a few more minutes, right? Now, psoriatic arthritis, let's take a look here. So another little bit of biology here, but same concept, right? Here you have a different cell type that's at the front and center that you find in your synovios, in your synovium, right? Synovium is where you actually have your synoviocytes and your chondrocytes in the joint space. That's where you have that inflammatory disease, joint inflammation, right? So the key player here that tips everything off is the macrophage. The macrophage, just like we saw for the dendritic cells in the prior slides, can have an adaptive immune response that is IL-23 dependent and a innate response shown below that is IL-23 independent. When you have adaptive, you have T helper 17 type cells that can release IL-17 family cytokines. And here, what they do is they go and start to bind to your synoviocytes that look like fibroblasts. Where else do we see fibroblast-like cells? In the skin. So you start to see themes of these of this cellular architecture. So your joints is very similar to your skin, by the way, for that reason. So you have your fibroblast-like synoviocytes that are receiving IL-17, and those synoviocytes do a number of things. They start to swell, right? So you can get some edema there. They have hypermetabolic activity, so you can see that on PET scans, right? They can affect the spine, and that can lead to bulging discs and so on and so forth, as well as synoviocyte hyperplasia, just like you can find in the skin. What happens here is that your synoviocytes are pro-inflammatory. They release cytokines such as interleukin-8 to cause neutrophil chemotaxis, right? We're starting to see the theme of neutrophils being important for psoriasis, now arthritis, psoriatic arthritis, so we'll see that for HS. And also, these synoviocytes release further chemokines that can act on the adaptive cells to bring more Th17 so that you have more interleukin-17, so on and so forth. And then similarly in the bottom, for the innate part of the immune system, you have other interleukins that these synoviocytes are releasing, such as interleukin-7. We barely talk about interleukin-7, if at all, but what you just need to know that it is a part of the family for synoviocytes that are causing for more innate cells to come in. More of these innate cells will produce more IL-17, such as ANF, and the whole cascade, right, is doing its thing. Same like plaque psoriasis, right? That's the theme. That's what I want you to take home. Same kind of concept. Nature repeats itself. Nature likes to repeat itself. And similarly, like plaque psoriasis, right, in arthritis patients, here looking at the actual synovial fluid, right, we had rheumatologists go in, stick a needle in that big joint space, suck out the synovial fluid, and then they measured the protein in there, right? They got that cloudy fluid, they stuck it into a reader, and they found that IL-17A was more greatly expressed in arthritis, as well as 17F in these arthritic patients, right? And then furthermore, looking at the patient's blood, you see that there's also increased expression as well. So 17A and F are quite important in psoriatic arthritis patients. And as we get to round the bend here for the last couple of minutes, we'll look at hidradenitis suppurativa. Right, a quick review of HS. We think it is a follicular-driven disorder where you have a follicular plug, if you will, that is genetically driven. Then you have this inflammatory response. Yeah, that is perifollicular inflammation that leads to an IL-17 cascade from your adaptive immunity as well as your innate immunity. And you have neutrophil chemotaxis that come in there. They cause an inflammatory storm leading to these deep tunnels, right, that are bridging with each other. You have fibrosis, you have fibroblast activation, so on and so forth, right? So what did we find here? Similar to psoriasis, similar to psoriatic arthritis. IL-17A in direct HS lesions was up to 149-fold greater expressed than uninvolved HS skin or healthy skin, right? So there's a huge increase in IL-17A, and you can see a difference between perilesional skin and the HS lesion itself. You also find IL-17F to be a whopping 155-fold increased expression in HS lesions compared to healthy skin. So these numbers alone tell you it's like there's a huge burst of IL-17 A and F response that is critical for HS disease state. And what we know with that is that it leads to neutrophils coming in, causing a neutrophilic infiltrate, right? So we think that there's a huge neutrophilic response in HS. That's why back in the day we used to use a lot of dapsone for these patients, but we know just one part of the disease, right? Now, how do we know that really IL-17 is so important for this neutrophil infiltration and perifollicular inflammation? We did we have seen a gene expression study. This was published in the British Journal of Dermatology a couple of months ago this year. When you're looking at HS patients, right, you're taking lesional skin and doing a gene expression study, you see that for the control tissue, right, without treatment, you see that this is a subset of genes that are involved in neutrophil infiltration and activation and migration, and these are highly expressed, red, okay, through the roof. With IL-17A blockade, okay, we're using a antibody that blocks only IL-17A, you see that this neutrophil gene expression box, right, starts to cool down. We're bringing this overexpressed genes back toward normal, so the reds become yellow and slightly green. But here's the take-home point. When you have dual blockade of IL-17A and IL-17F, that reduction in those genes goes way back toward normal, way back towards center, right? Much more green there. So the key thing here is that there's like a dose dependence, if you will, the way I look at it, for hitting the number of cytokines, and particularly here A and F. We need dual blockade of A and F to truly reverse that gene signature to really stop that neutrophil activation and infiltration. And this is evident by the most recent BJD paper. Okay, all right. And then furthermore, so you can, so in another part of the study, not just looking at the gene expression, but they also measured the amount of neutrophils on a petri dish, and they found that there's less amount of neutrophils that got in, that got into the sample. So perfect. So that's the cellular effect. All right. So ladies and gentlemen, we spoke a lot tonight. All right. So the key take-home points for IL-17 biology. All right. There's yin and yang. IL-17 family of cytokines is important in disease and in health. All right. Not only in psoriasis, not only in HS and psoriatic arthritis, but also in neurodegenerative disease, tumorigenesis, microbiome, wound healing, you name it. All right. IL-17 production, right, with the numerous cytokines that there are, A through F, right, and the different subunits of the receptor, you can have many roads leading to Rome. You have the adaptive immunity that is IL-23 dependent, that can lead to a Th17 response with production of IL-17s, but you can also have the innate arm, which is IL-23 independent, right? Don't forget that. And in their own right are producing IL-17 by themselves without IL-23, right? And then this regulation of this response leads to different disease states like we just talked about. And don't forget that the dual blockade, right, of A and F can lead to greater reduction of that memory T cells that are found in the skin in psoriasis, as well as those neutrophilic response and neutrophilic gene expression parameters, as we saw for HS. And I believe on that note, ladies and gentlemen, thank you for your time, and I will pass the baton back to Dr. Kursik.
Dr. Issa, that was wonderful. I learned so much. We have a bunch of questions from our audience. They're all excited. So number one is, actually, it's very interesting. And the perception is that, and including myself, going back 10, 15 years ago, we think that, well, IL-23 is the main valve. We block the IL-23, then of course we're gonna be blocking IL-17, right? But now you're telling me that that's only one of the pathways. That's the adaptive immunity, and then there's also, we have that innate immunity. Tell us a little bit more about that. So basically you're telling me that IL-17 blocking, it's gonna block all the IL-17 and IL-23 dependent pathway. If you block the IL-23, it's not blocking all the IL-17?
Correct. Okay, so if you're looking at the classic teachings, right? Classic psoriasis, psoriatic arthritis teachings, right? That you're going through TNF, then TNF leading to IL-12, 23, then 23 cascade down to 17, right? Which is a great path, right, to inhibit. And we've been doing that for ages, right? But as we just saw, it is not sufficient to block the entirety of IL-17 production. We have gene expression studies actually not listed here that actually prove that point within the last decade. So we know, the pearl is that IL-23 blockade, while it's excellent, all right, at the same time, it is not sufficient to block the entirety. And that is important, especially when you think about non-responders, maybe going straight to the Achilles heel.
So the next question is digging a little bit into IL-17 itself. So just blocking IL-17 alpha receptor, is it enough to block all the IL-17 in the system, either skin or in the blood?
Okay, if I understood that question correctly, we're looking at blocking receptor, right?
Yeah, IL-17 receptor alpha blockade. Does it truly block all of the IL-17 signaling?
Yes, and this is very important concept, because our traditional understanding has been that first of all, IL-17 receptor blocker, of which there is only one, right? This is brodalumab, is what we're referring to. It blocks the subunit receptor alpha, not the whole, not both of the subunits. Remember, there's two subunits, but it does a very good job of blocking a lot of the cytokines. Fine, but what we know that, as we saw, is that there are other subunits. So we saw IL-17 receptor C that can dimerize with itself and still allow for some residual IL-17 and A and F signaling. So my interpretation is that we don't have full blockade like we originally thought, and that's also important.
You talked a lot about the T-resident memory cells. Is that because why do we get the disease always in the same spot? I mean, not always, but it comes back in the same spot, such as the elbows and knees. Is that where they are?
So to my understanding, okay, you can have them in lesional skin, and as we saw, non-lesional skin also had that. So it's twofold. Yes, you can have the disease come back in the same place, but you can have new disease in its own right that can have a trigger, let's say a viral infection or staph or whatever, also from Kebnerization as well in a distant site. So I think it's two reasons.
And tell us a little bit, you had a recent article at JCAT, and do we have any evidence that really we have this remittive effect if you block the T memory cells with dual IL-17 A and F?
So you're hitting on a very personal subject that I care very deeply about. Thank you for bringing up my article. So for those of you who are unfamiliar, so I did publish an article looking at the IL-17 class of molecules, right? All these different inhibitors, and was I able to try to find something that could explain why when you treat to clearance and you stop the drug, the time for the disease, for psoriasis to come back, is there a difference between the different biologics, right? And I looked at secukinumab, ixekizumab, which are IL-17A blockers. I looked at brodalumab, which is the receptor blocker. I also looked at bimekizumab, which is the A and F dual blocker. Interestingly enough, right, the summary of what me and my partner, this is Dr. Chris Bunick, we teamed up to do the study. What we found was that the pharmacokinetics, right, how much bioavailability, how tightly the biologics bind to their intended target, and their half-life did not necessarily dictate what happens once the drugs are discontinued, looking at the placebo withdrawal arm after getting clearance. So essentially, let me give you an example. So ixekizumab and secukinumab, similar epitopes, not exactly the same, right? But same target, if you will. Slightly different binding kinetics, all right? But for all intents and purposes, the same. But the main difference is their half-life, all right? One is about 19 days and the other one's about 24, 25 days. And so secukinumab actually had a better off-drug response, and that is because that there was a greater half-life, right? They stayed in the system longer. Fine. When you bring in bimekizumab had a 22-day half-life, right? And what we found is that beyond 5 half-lives, there was an exceeding amount of patients that still had greater than PASI 75, all right, but response. The drug is out of the system entirely, right? What else could explain that? We believe it is due to the memory T cell response, all right? And I hope that we investigate that further with more basic science.
I think that's really the key, right? Can you give a shot once a year or twice a year and keep the disease clear? That's sort of what we're getting into slowly but surely. Now, the other thing is there a PASI score severity, right? When we look at the IL-17 and A and F concentrations in the blood, how does the PASI score severity change or differ?
So what we were talking about for where we have IL-17A being the relation with PASI severity and 17F, not so much. Is that what we're getting at?
Yeah.
Okay. So both are, so from those graphs, I believe that there's truly an association in one way, shape, or form. But what seems paradoxical to me, and maybe some of the audience, would be that 17F should have a greater correlation, but we don't see that with PASI severity. I actually think that this is uniquely important because this would tell me as a biologist that 17F is so critical to the disease state that it needs to be there at all times at a certain level in order to start the disease and maintain the disease, right? And so maybe there's a relative slight increase, with the different disease severities, but it's still highly expressed from the get-go, and that maybe lack of change doesn't really matter that much, but it could mean that again, it's a cornerstone of the disease. You need it to be there right from the beginning. So it means that 17F is very important.
Thank you. So we have a couple of more minutes to go, and I do want to touch upon one thing that I heard, if I heard correctly. I heard protective effect, if I heard correctly. So, you know, every day in real life, it's not a study, clinical study business. We get patients with bad psoriasis, with prostate cancer, breast cancer, lymphomas, leukemias. What do we do with those patients, right? We always are concerned. Can you a little bit discuss about the impact of IL-17 inhibition in those patients in malignancy?
Okay, this is, you know, special type of patients, right? It goes to, you know, this discussion about when we look at HIV patients, patients with latent TB, with hepatitis, so on. Now we have malignancy patients. We have to look at malignancy patients in two perspectives. Okay, this is why I believe two perspectives. Those with prior history of malignancy, all right, and that have been treated and are in remission of their malignancy as one category. And then you have patients with active malignancy who could be currently treated with immunotherapy, chemotherapy, and so on. And that could develop psoriasis, for example, during their immune checkpoint inhibitors or so on.
Sorry to interrupt. Give me a definition of the prior remission. 5 years, 10 years, 3 years?
So interesting. So standard teaching, all right, and Dr. Kursik, you know, you've been around longer than me. Classic teaching has been 5 years, right, before we think about using biologic, but studies more recently looking at retrospective reviews has been even up to 3 years and even 1 year, because waiting 5 years is a long time, it's half a decade, and some of these patients are really suffering. So the more recent epidemiologic studies have been focused on less time since the disease remission, more so at 3 years and 1 year. What they've found, so these are mostly the Italian studies, by the way, right? So those are interested. They come out of a consortium of these Italian academic centers. These studies showed that, especially for IL-17A blockade, right? And we're learning more with the dual blockade because it hasn't been out that long. But for 17A blockade, we are seeing that there's no evidence of increased malignancy relapse in these patients within the 1 year and the 3 year mark, let alone the 5 year. So there is a good amount of safety there for these prior malignancy patients for as early as 1 year you may want to consider. Now, to the second arm of your question is patients with an active malignancy. This is a different grab bag, and I'm going to caution you in terms of using IL-17 blockade because it's so topsy-turvy. Again, so there are going to be some examples where IL-17 is important for metastasis. Okay, so IL-17, I have a list of these cancers. IL-17 will promote cancer progression for breast cancer, hepatocellular, osteosarcoma, as well as colon, okay, as we saw also in the deck. So here, maybe if you have a psoriasis patient with one of these malignancies like breast, maybe just theoretically could be protective if you give them a 17 block. But then you have other malignancies where you may want to reconsider. These include gastric adenocarcinoma, esophageal squamous, ovarian cancer, leukemia, lymphoma, cervical adenocarcinoma. Here, IL-17F is acting in an opposite way. It's actually protective. So maybe by taking away those protective guardian, you're going to allow for more disease progression. So I think there has to be a lot more discussion with the oncologist and really looking at that basic science. We're not there yet, but I think now it's time for those discussions. Furthermore, one last piece where we still don't really know what's going on is if you have, let's say, a melanoma patient that's on immune checkpoint inhibition, develops psoriasis, psoriatic arthritis, does blocking IL-17, whatever cytokine it may be from that family, does that lead to a poorer response because of those CD8 cytotoxic T cells that are circulating or not? I want to investigate this. We're going to find out in the next year or so with some basic science. So summary is that we don't really know for the active malignancies, but we do know for those with prior malignancies. That's the summary.
That's great. We're almost on the top of the hour, but I do have a burning question, and that's gonna be it. So one more question, and that is, if I heard you correctly again, IL-17 plays a role in neuronal degeneration, dementia, depression, right? However, on some labels of some products, right, IL-17 products, we have depression, we have suicidal ideation, behavior. So how do we balance this? So can we say that really it's not the drug, it's IL-17, it's the disease that happened during those clinical trials?
You know, it's such an important question, right? It is it's something that I think about a lot. I believe we can't say. There's no way. You saw that picture of the different cytokine subunits and the different receptor subunits, right? First and foremost, I'm going to say that the rates of depression and suicidal behavior, suicidal ideation, all that jazz is, while it was present, it was low. What is the adjudication on that? We think that there may not necessarily be an association to the drug. We already know this, right? But we are the class, right? We are looking at blocking different aspects, and that can lead to different cytokine milieu, if you will. So it's not the same as just blocking 23. So we need to investigate further, like, is there a particular subtype or isoform that's more important in neuroinflammation and so on? I believe, yes, there is something there. Could there be an association with other, you know, comorbid conditions? I believe, by the way, that acne is actually one of them. I think there's IL-17, maybe E that's important there. Again, stay tuned, but I think there's a lot more to unlock after seeing this information.
Now that you brought that up, actually, I remember doing an acne study with IL-17 blocker. So it's interesting. So this was a very, very eye-opening program. I truly appreciate your wisdom and your knowledge and your scientific aspiration, all those. And I do want to thank UCB again. And I love that they are inspired by patients, driven by science. It's been great working with them. And I thank again for supporting this program tonight. And then please stay with us up to date. Next December 1st, next Monday night, we have a great program with Dr. Sarina Elmaria as well as Dr. Jason Hawks. They're gonna discuss atopic dermatitis and prurigo nodularis, clarifying perspectives and common misconceptions. Again, this is gonna be one of the very interesting, mostly disease state lectures. I thank you so much and have a good night, everyone. Thanks again.
Good night, everybody.